Let everybody in. Okay, thanks, Connie. All right, this meeting's called to order. Good morning and welcome. Our meeting going forward here at the Healthcare Authority is going to be hybrid. Staff will be on site as much as possible, and other attendees, both board members and the public, will have the option to attend on site and here in Olympia or via Zoom. For our Zoom attendees, our opening slide has information on how to turn on the closed captioning subtitles. We're going to do a board member roll call. Kurt Spiegel.
Present.
Monica McLemore. Oh, Monica's out. Okay. Elliot Weinstein.
Here.
Harry Bossy.
Yes, here.
Tom McRobert.
Oh, did you hear me? Here.
We did. We got you. Tom McRobert.
He's here. He's on mute.
I see you, Tom. You got your. Give me a thumbs up. Bingo. Awesome. John Comerford.
Here, present.
Excellent. And Michaela Dolman.
Present.
All right. And Michael Tunick from the AGOs.
Present.
Awesome. And I'm Lou McDermott. I'm filling in for Sue Birch as Chair Pro Tem. Sue is currently away on business, and it's always great to be back here and a part of the PEB team. With board members attending both in person and virtually, it's going to be helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members are also going to be watching you in case your Zoom hand goes up. There's no resolution scheduled for action for today's meeting, so the public's going to have an opportunity to provide general comments at the end of the meeting during the public comment period. As a reminder, if you have questions during staff presentations, the presenter's contact information is included at the end of the presentation. You're welcome to email them during the meeting to capture your question for response in or after the meeting. Dave Eisminger, the PERB Director, is going to provide an overview of today's agenda. Good morning, Dave.
Good morning, Chair McDermott and members of the board. Just a quick comment. That reminder about staff presentation contact information is more for the public than board members. We've always encouraged board members to ask questions during the presentation, but I know that as we were opening public comment earlier this season, that there were requests for a variety of different times for speaking, and just wanted to remind people as to how they can capture their real-time questions for staff to be able to respond to. So today we have quite a few presentations for you. Legislative session, the regular legislative session, I guess I should say, is over. And so we'll have Kate reviewing what bills have been acted on fully by the legislature. Most of them that you've heard them on have already been acted on by the governor as well. And then Tanya will bring you up to speed on the final legislative budget that was passed, which is still subject to the governor's review. He has until next Tuesday to act on the budget. Then we're going to bring back, I think it's our third meeting in a row, some information about hearing instruments and bring forward a proposal for discussion and then future action by the board, specific to the Uniform Medical Plan. And it also dovetails with the bill that Kate's going to bring you up to speed on as well. After a quick break, we wanted to bring you some information related to the First Bill program that's in Kaiser, Washington. That presentation is more designed just to share generally how information, use First Bill as kind of a case study example of when a benefit changes in the PEB portfolio after board season. What is the process that we typically go through at HCA and with the carrier to convey that type of information? And I wanted to just share that with the board, as well as hear feedback on other ways that you think we may be able to communicate. So it's designed just to kind of fill in that gap to show everyone how it is that we generally communicate about benefit changes in a very important topic that has come up with quite a bit of questions so far. And then Ellen is with us, as always, to do some more topics within our Medicare debate, some follow-ups to previous questions this board season, and just keep you up to speed on our retiree engagement. We'll have public comment and then an executive session. And with that, I turn it back to you, Chair McDermott.
All right, thank you, Dave. And just for housekeeping, the bathroom is down the hall on the left for the people in the room. And if the emergency thing gets rung and we got to go evacuate, we're supposed to meet in the parking lot right across the street. So, All right. First agenda item, approval of the meeting minutes. Today, we will vote on one set of meeting minutes from the April 13th board meeting. Minutes are behind tab number 3. Are there any comments from the board? No? Do I have a motion to approve the minutes as written?
So moved.
Is there a second?
Second.
All in favor say aye.
Aye.
Any opposed? All right. The April 13th, 2023 minutes are approved as written. Next agenda item is the April meeting follow-up. Dave's going to give us some, I believe, a follow-up to some questions that were asked at the last PEB board meeting. Materials are behind tab number 4.
Yes, all right. Good morning again, Chair and board members. I have, I believe, 2 questions that are in the slides and then another piece of general follow-up information to keep you and the public apprised of progress on a project. These are just things that don't neatly fit in other presentations of the day, so I back clean up at the beginning of the meeting. So the first piece, as we move into slide 2 and 3, is about smart health registration data. This was a question I believe that Chair Birch asked for a refresh that included at least the information so far in 2023. So the information that's on these slides for 2020 and 21 and 22 is all the same information that was presented at the most recent board meeting by Kristen Stoyanoff. But 2023, the first roughly quarter quarter and a little bit more data about registrations, the number of people who completed assessments, that roughly 2,500 individuals who have already qualified for the incentive for the next year, and the general participation level. That last row is just the additional information that Chair Birch asked for current engagement within the Smart Home platform. So wanted to bring that back. Elliot, I see you have a question.
Yes, I'm just curious, maybe it's obvious to everyone else, but why are the participation rates going down? I'm just curious, or maybe that's already been discussed.
Well, one of the things, 2023, remember, is partial year data, and so that number always grows over time. So for 2023, for example, there's 16% participation of the population up through April 23rd, whereas the other 3 are the full calendar year participations. So there's just one piece to keep in mind, that that 16% is a low watermark. It's not a high watermark. It will definitely grow over time. And then I believe Kristen provided some information last meeting about some of the differences. I'm recalling them right now. That last year there were a couple of different aspects of the Smart Health program that we think made it challenging for individuals. One of them was transitioning to SAW and having to go through Secure Access Washington at the same time as Limeade, the vendor for the portal, did an overhaul of its platform. And so there were a couple of different aspects of engaging with the platform that were just kind of fundamentally different, and we think that that had some aspects to do with it. But I know that Kristen and the team are being vigilant on it, and it's really important to us to see how 2023 shapes out. But that was some of the theories behind 2022. All right, any other questions on this? I will next go to slide 4 and 5, with just a little bit more information about the Dependent Care Assistance Program. So the question last meeting that we were looking to follow up on was just information about if the individual who's paid for providing the care is required to be legally authorized to work in the U.S. And so as we move to slide 6, quite a bit of information here from IRS resources directly. That essentially there needs to be a good faith effort for providing the information that the individual is legally authorized to work in the U.S. But there is ultimately some leeway as long as you're providing, making good faith and due diligence efforts demonstrating to provide it. So the answer is generally yes, with some grace for due diligence in providing that documentation. And then we can go ahead and put it on my questions, but I have one other piece that isn't in the slides. I wanted to make sure to give a little bit of an update on Benefits 24/7. This is the online enrollment portal that we've been talking about launching, and we've had some presentations last year and earlier this board season. I wanted to make sure to call out that board members should have received an email from me about 2.5 weeks ago, around April 25th, that we originally had scheduled the launch of the program of that system for this month, May, but we rescheduled that to June 12th, so just about 1 month out. And I wanted to share with everyone in the public as well as some of the reasons why we made that shift of a 1 month reschedule. First of all, it's really important for us to just thoroughly test data migration from the current accounting system of an enrollment system of Pay1 into this new system. That really makes sure that we don't have to ask our benefits administrators in PEB agencies and higher education to manually key or migrate over information in the manual key process. And we just wanted some additional time to make sure that that migration efforts work to our satisfaction, and that's a very key piece. The other part is we thought it would be good to give some additional space for training staff and benefits administrators in the PEB system and have more ability for additional time for them to ask questions of HCA. At least at the time when we were making the decision, we were still in the early stages of participation from benefit officers in the PEB program. And so we just felt that that extra space and training opportunity would be good. And also, we had not yet finalized some of the key communications that we were going to be mailing directly to members yet. And so we wanted to make sure that we could share that with some of the benefits administrators as well, get some feedback and finalize those. The last piece is we have to re-enter the authorization for each agency's authorized individuals for accessing the system. And at the time we were making the decision, we only had about 1/3 of agencies from the PEB program that had given that authorization, or the names of those who needed to be authorized, and about 1/4 in the SEP program, because they're also moving into the system. And so there was, we had some concerns that we needed more space and for that information to be received from each of those entities, whether it's a school district, higher education institution, or state agency, and for us to key it in, because if we turn on the system and 2/3 of the program didn't have somebody authorized to access it, that is not a recipe for success. So for all of those reasons, we said, a 1 month reschedule made sense to us. We did some notifications of this through a variety of emails through stakeholder groups, updating our project webpage, and sending information to the benefit administrators in both the PEB and SEP programs. So I just wanted to provide some of that context on that important project and let you know that we are gearing up for a June 12th launch. Elliot, I see a question.
It is a very important thing you're doing, and I'm grateful for it. My concern, I've heard from members, I was in the test group, and I didn't even know how to use SAW. So you've got sort of a double hurdle there. How are you going to deal with people that don't know anything about SAW? SAW is, I would personally, for me, difficult. So I couldn't even get into it.
The good news is we have experience with helping people understand SAW, because we had to educate school employees about SAW as they were entering a similar online system than when we were launching the program. So a couple of things are, one of the materials I was just referring to that we wanted to keep finalizing it's a quick start guide in how you enter the system, and it has specific instructions and navigation for accessing and going through the SAW process. So we have that guide, and we're strategically mailing it because we learned in the SEP program, if you mail it too early or too late, you gotta mail it at just the right time. If it's too early, people want to get into the system, or they may lose or misplace it. If you send it too late, then they're asking questions because they don't have the guide yet. So we're working on the strategic mailing of that, and we're also making sure that benefits administrators and PEB agencies and higher education institutions also have that information. And then ultimately, we have a dedicated 1-800 number for people who are working through that information, which will also be printed online and accessible, and people will be directed to it as part of the original enrollment process. So it's both online and a print version that they're getting, but if they ultimately have questions, there's a dedicated number that they're going to be able to call for people to help them navigate through SAW. And that's essentially the techniques that we use for launching the SEP program, and we found that to be pretty successful. The other important thing is some people, more and more people are getting experience with SAW because a lot of agency programs are being put behind SAW. It is the central secure portal process and multi-factor authentication process that the state of Washington has developed and is being put in front of a lot of systems throughout state government. So, if you, for example, if you sign up, the Department of Licensing has a process that includes it. The unemployment insurance has a program that fits behind SAW. So there is at least some part of our citizenry that is getting more and more used to SAW, but we are certainly here to help everyone through that process if it's their first time.
Other questions for Dave? Other questions for Dave? All right. Next agenda item is legislative session debrief. Cade Walker, the Policy Rules and Compliance Section Manager in the ERB Division, is going to share some updates on the bills that passed in the 2023 legislative season, at least the regular season. We have a little overtime coming up. Materials are behind tab number 5. Welcome, Cade.
Good morning, Chair McDermott and members of the board. I'm happy to be here with you this morning to share with you a debrief of the end of the regular session. For those of you who aren't aware, there's going to be a special session coming up here, I think starting next Monday, to address the specific issues regarding the Supreme Court's Blake decision, or the state Supreme Court Blake decision regarding criminal charges for drugs. But notwithstanding that, we did finish out our long legislative session successfully, I will say. It's been a good session for us, and our team did a fantastic job. All 25 analysts, our support team, our fiscal team, everyone did a really fantastic job this year. So here's our quick debrief here of things. So next slide, please. Our full scope of the number of bills that we conducted analyses on. While the total number of bill analyses this year is a little lower than we had in prior long sessions, we did have a significant number of high priority ERB-led bills where the main impact to the agency was deemed to be in the ERB division, which is the PEBB and SEP division. And so we had a lot of high priority bills that we were tracking this year, which was great. It's good to see a lot of work being done by the legislature that can have impacts on our programs and keeps us nice and busy. Also, we had a substantial number of fiscal notes this year. Unfortunately, it did peter off towards the end of the session, but we did have a lot of fiscal notes. So it's great seeing the attention from the legislature on the program and being able to make adjustments and changes to make improvements to the services we provide. Next slide, please. Here's our funnel of all the 38 high priority led bills and where they landed throughout session. You can see at the bottom we did have 12 high priority pieces of legislation that passed and either have been signed or just a handful of them that are awaiting signature. So a pretty full session of analyses and impacts for the program this year. Next slide. So I'm going to go through, and I somewhat regret that I put these in numerical order, but it seemed to make sense at the time, as some things do. But so it bounces around topics a little bit. So I've got 2 slides about the new laws, with a couple of them that are still just awaiting signature, but we don't have any reason to believe they won't be signed. Of new legislation that is going to have direct impacts on the ERB program, either administratively or in the benefits that are offered. So starting with 1008, Plan 2 members, this is expanding the definition of separated employees to now include Plan 2 members that retired under the either PERS, SIRS, or TERS retirement plans. The separated employee definition is important because it allows certain individuals who have separated from state employment after having hit a number of service hours. They're at least 55, but they are not going to be drawing a pension yet. But they have eligibility to enroll in retiree benefits prior to starting their pension or drawing on their pension. And so this 1008 expands the definition of that to now include Plan 2 members, where before it only included Plan 3 members. So effective 1/1/2024, Plan 2 members will be able to separate from state employment prior to drawing a pension and can join and still can join the PEB retirement benefits. Then we have 1222, which I won't go into much because Janice will be here to speak about that more in a moment, that expands the scope of coverage for hearing instruments. We had 1357 that again I've got a slide on to talk a little bit more about per Tom's request, where the legislature has expanded certain requirements regarding prior authorizations from commercial insurance carriers. 1804 PEB employee group retirees, and this is resolving a minor issue that was discovered recently where retirees of employer groups, and now employer groups are those entities that participate with the PEB and now the SEP program on a voluntary basis. Those entities are like cities or counties, water municipalities, sewer districts, fire districts, the government-related entity that's not a state entity can contract with the program to participate and bring their retirees. So if they decide to leave the PEB program or the SEP program moving forward, they're supposed to take their retirees with them. We discovered that sometimes they will take their retirees with them, but then offer no coverage and instruct them just to go to the open market, which is not great for them. So 1804 establishes a process, or establishes the authority for those individuals who are retired or disabled employees of an employer group that leaves the PEB or SEP program to remain in the retiree coverage without any subsidization payments, but they are still able to access our Medicare or non-Medicare risk pools. Then we have 5242, which eliminated any cost sharing for abortion services for commercial carriers. 5275 establishes that same sort of employer group permission for government entities that are not otherwise required to participate in the SEP program now can participate in SEP on a voluntary basis. Those entities, different from the PEB side, are tribal schools, the associations representing school employees, such as the Washington Educators Association or the public school employee labor groups, as well as allowing the board members from school districts to participate in SEP, all on a voluntary basis. Next slide, please.
Real quick, Kate, I'll just let everybody know that the prior slide and this slide, all these bills have been acted on and signed by the governor. Back to you, Kate.
Thank you. Then we have 5300 regarding expanding the accessibility for certain behavioral health prescription drugs for continuity's sake, so if there's any disruption in care or transferring between providers, for making sure that that's taken care of, to make sure that members have access or individuals have access to their behavioral health prescription drugs. 5396, eliminating cost share for breast examination services. 5421, this is the Public Records Act exemption that we requested regarding any of the enrollment information for either the PEB and SEP programs. So now there is an exemption in the Public Records Act regarding any information collected as part of the enrollment process for either the PEB or SEP programs, which will have really great impacts downstream for us in our efforts to collect information to address health equities and health disparities in our population, as well as access issues in our PEB and SEP populations. There's 5490, which creates a very narrow opportunity for creates an opportunity for a very narrow population of retirees to join the retiree program, even though they may have missed that opportunity due to a failure to submit a deferral form. And so we're currently working on implementing that. I'll talk more about that in a moment. 5700 was our agency legislation, agency cleanup legislation, which just helped us take all of the different sections of statute that have been compiled over the last few years as different groups have joined the agencies, specifically DBHR, and also giving us a chance just to clean up a lot of our statutes since that passed, and we'll have that a much cleaner set of statutes moving forward, which will be nice. Then last on our high priority is the insulin cost sharing cap, which capped the cost of insulin for a 30-day supply at $35, and that has now been re-upped for the next for the foreseeable future, as well as some cost increases that will be aligned to consumer price index increases over the years. So that now is going to be more of a permanent cost cap on insulin. Next slide, please. So a little bit more about 1357 regarding prior authorizations. This was a question, Tom, that you had asked to have a little bit more information on. So HB, House Bill 1357, really has three key components to it regarding what it does in changing up the prior authorization process for commercial health insurance in the state. First, it has new timeframes, more expedited timeframes in which the prior authorizations must be completed by, and that goes into effect 1/1 of next year, January 1st of next year, making those timeframes shorter to ensure a more timely process for those prior authorizations to be completed. Now, then starting in the subsequent year, in January 1 of 2025, there are new electronic authorization standards, and I think the best example of it that has been explained to me is that if they're in the prior year or some other time frame, if there's a certain number of prior authorizations for a procedure or a medication that is approved at a high rate or high percentage, 95% of the time it's approved or more frequently it's approved, then in those instances there can be either truncated or an automatic approval when certain procedures or medications subject to prior authorization are approved. So I think it's a kind of a smart way the legislature is looking at, well, if you're approving 99% of these prior authorizations for this medication, then why are we having prior authorization just be a barrier to accessing care? And so that will go into effect starting in 2025. Last, there's enhanced communication requirements the carriers have in providing notice, both about the timing and the process for prior authorizations, as well as the in-process of seeking prior authorizations. And that too goes into effect at the start of next year. So I want to just check and see if there's any questions. This does apply not only to all of the PEB and SEP programs, which was explicitly stated in the legislation, as well as also explicitly calling out its applicability to Apple Health, the Washington State's Medicaid programs, and as well to all private health insurance carriers out there. So I want to just take a quick pause, see if there's any questions, or if Dave, you had anything else you wanted to add? Okay, great. Next slide, please. Going through, there's been quite a number of new laws regarding providers, either expanding their current scope of licensure or certification, or creating new certification and licensure for them, or also entering into multi-state compacts or agreements where providers who are certified or licensed in other states, specifically in our border states, we will recognize those licensures and vice versa for our providers within the state. So starting with at least one of those, we have a mental health counselor compact that expands or has Washington participate now in a multi-state compact regarding mental health counselors, so that our counselors can provide services to patients in other states such as Oregon and Idaho who also participate, and the providers in those areas are able to provide services to individuals in our states as well. Medical assistants saw the scope of the services they can provide expanded under their licensure from DOH. We saw a number of bills addressing dental work, which I'm not necessarily thrilled about. I'm sure it is great and wonderful and helps out with things, but I'm still going to be terrified by dentists. And looking at 1683 denturist, it seems even a little bit more terrifying. I'm not sure what that is. It sounds even more painful than just a regular dentist, but I'm sure these are all really great and valuable for our populations. So having expanded scope of services of our dental hygienists, having the dentist compact agreed to that our state will now recognize licensures of dentists from other states and vice versa, expanding access to dentists for those who regularly see dentists like Dave. I can see Dave's come off mute. I'm sure he's got some wonderful positive things to say about his incessant use of dental services, appropriate use of dental services. I've had some trauma with dental services in the past, so it always gives me that little tingling thing on my arm. Denturists, will say,
I was just going to say, Dave, just yin to some yang. We have plenty of support for dental services here at the Healthcare Authority. And it's an important part of preventive care. It can be a big indicator of future health. We've taken a lot of strides to encourage people for dental care. And so just want people to know that we have a lot of support, even though we know that there are many people who share Kate's experience and concerns. So it's really important to promote good dental health and practices as children. That was my personal experience, and I've said many times before in public meetings, I love going to the dentist, and so we have a lot of support here, and it's a really important part of dental care. I'll also close real quick by noting that all the bills on this list have been acted on this slide, with the exception of 1678 so far. So just wanted to say that. Ellie, you might have a question.
Well, I was going to say, as you can see,
Very quickly, denturists provide dentures. Kate, I don't think you're going to be seeing one of those people very soon.
Well, you might be surprised, because my fear of dental work might lead me down that track even sooner. But I will say, I have grown up and listened to Dave and those around me and our partners with Lamin and Delta Dental. I did have a substantial amount of dental work done last year. It's still a work in progress. It's really important. I'm glad to know the dental therapists I know are a great mid-level provider that will be really important for rural areas and seeking care. So it's a really great equitable piece of legislation in the creation of dental therapists to be used in kind of that mid-level capacity that's popping up. So thank you, Elliot, for the information on denturists. I'm sure I will need one from you. Next slide, please. We see a couple of new provider types in the behavioral health space, which is really timely. 5189 behavioral health support specialists and 5555, which 5555 hasn't been signed yet, but creating a certified peer specialist. So both of these are really important provider types for the behavioral health services that we certainly know we need more and more of in our state, and I think really everywhere. We saw the creation of the home care aid certification for home care aides, being able to help individuals as they age or need in-home services, be able to receive those in-home rather than in facilities or in residential facilities. Expansion of the scope of services that optometrists can provide, and the multi-state nurse licensure, similar to the dentist compact and mental health therapist compact. We will see in an attempt to help address nursing shortages, respecting the license or acknowledging, recognizing the licenses and certifications of nurses from our border states. Next slide, please. So a couple of new service lines. And this first one is just another fantastic one. If you love dentist work, you're probably going to really love the idea of intramuscular needling. I haven't really had much of an opportunity to get under the skin of what this legislation, what the service type is for this. Oh, that was a bad joke. But it's now a service that is being required to be provided by commercial insurances. We did see expansion in the telemedicine services being provided and furthering the use or supporting the use of telemedicine to provide access, especially for remote areas and in other types of service types where it makes a lot of sense to be able to use telemedicine in its different formats. So expansion on the Death with Dignity Act, and then 5581, creation of specific maternal support services and looking to increase infant survivability rates and maternal support both pre and postpartum. Next, I see a question from Tom. You've got a question.
Yeah, I am puzzled. I do not know what intramuscular needling is.
So I'm not great at knowing what it is. I know that it's not quite the same as acupuncture, and that there's different procedures that are contained in the nomenclature of intramuscular needling. I would be happy to look into it more for you if you'd like, and have some things reported back out. I might defer to our bill analyst on it, who would seem to be a lot more excited about the opportunity of having intramuscular needling included. It still gives me a bit of the heebie-jeebies thinking about just the sensation of it. That's it.
We'll bring more information back, Tom. We'll bring back some more information.
Okay, thank you.
Well, I just wanted to point out, this is Monica, as a nurse, I can just tell you that it's also used a lot in chiropractic and therapeutic situations for people who see people who have doctorates in chiropractic.
Cool. All right. Well, more information. Thank you, Dr. McLemore, and Tom. We'll bring back some more information at the next meeting. Or I'm sure did. Next slide, please. So I want to talk about. So we had 4 pieces of legislation that had the administrative impacts that impact our typical rule process, and it had implementation dates that were earlier than just the start of the next year, or cause us to have to get moving on things sooner than later. Which makes for a busy year for us. It's different than it's happened in the years past, with the exception really of the creation of the PEBB program, which is the last kind of piece of legislation that had a significant administrative impact on us. But this year we have had 4 pieces of legislation that we're currently in the process of implementing. Some that had emergency enactments, some that have enactments that are coming up very closely. And so I wanted to just give a brief update about the implementation efforts of that legislation, those pieces of legislation so far. And those are, those 4 pieces of legislation we're currently working on are 1008, 1804 regarding the retirees from employer groups, 5275, which is the creation of employer groups in the PEB program, which then also has implications with 1804 regarding the retirees from employer groups. And then the 5490, second bite of the apple. Really it's just a little nibble at the apple for a very select group of retirees to be able to return to come to a PEB retirement coverage. Next slide, please. So for 1804 and 5490, both of these had emergency enactment clauses, which states that once the governor has signed them, then they go into effect immediately. For 5490, what that meant is that the retirees who would be eligible to return to coverage, that they are eligible at any point from now until the end of open enrollment to kind of raise their hand to the program and say, hey, I think I qualify, please let me back into coverage. And then for 1804, the implication of that on the emergency enactment basis is that for the retirees from employer groups who lost coverage, meaning any of the employer groups up until the end of last year who had left the PEB program and had retirees or disabled employees who lost coverage because of, or lost, or didn't have any coverage when their employer group left, or they did have coverage but it was so expensive they were not able to enroll in it, or any reason at all, they're able to return to coverage as well. So we have retirees from 5490 and retirees from 1804 would be returning and have the opportunity to do so from now until the end of open enrollment this year, at the end of November. So the work that we're doing in regards to both of those populations, first is we're trying to identify who those potentially eligible individuals are. For the employer groups, that's a little easier for us because we had a list of those. We would have known a lot of who the retirees were when those employer groups left the program, and we're going back as far back as we can to determine who those individuals would be. We can attempt to reach out to them directly. 5490, it's a little more complicated because the eligibility criteria starts with them having to be Medicare eligible, and then we narrow that down a little bit, that they had to have applied and been denied from retirement coverage because they failed to submit a deferral form. And then it gets more narrow that they had to then have submitted an appeal of that denial based on the lack of a deferral form by the end of last year. And so the window of who would be eligible under 5490 gets very narrow, and we're trying to identify that population. In addition to identifying the populations, we're undertaking emergency rule writing. Our rule writing that Stella talks about and presents to the board at most of the meetings, our regular permanent rule writing begins in January, and we submit that to the code revisor around May or June of each year for implementation or effective date of 1/1 of the following year. But during that time frame, once we have submitted it to the code revisor and when it becomes effective, we can't tinker with those rules anymore. They have to sit there until they become effective. And so we have to enact emergency rules so that we have some process in place, some legally defensible process and procedures in place regarding the implementation of 1804 and 5490 and other pieces of legislation that we can do on an emergency basis. It has a short review window of internal only, no external review. And those rules stay in place for 120 days, and we can renew that, and we will, for some of these, we'll renew it until we're able to have the permanent rule writing done next year. And of course, for 5490, it will be irrelevant for next year because the window for them to return will close, and then that piece of legislation will no longer have any effect, say for those employees who have returned to retirement coverage. So in addition to the emergency rule writing, we are developing communication plans or making communication efforts in short order, including a website that has information about how to, for members who are potentially eligible to submit information to kind of have their eligibility checked and have their enrollment made effective. We're revising the process for re-enrollment and making sure we have everything ready for them to be able to make payments for those retirees that come back, and then providing specific training to staff. I'm going to pause there. Tom, did you have an additional question or a question about this?
Yes, I'm going to give you a hypothetical. So, let's say 10 years ago I was an employee of the Omac School District, and I didn't get very good information about my retirement healthcare options, and so I just decided not to sign up for healthcare, and then 5 years later I found out that I was no longer eligible because I had am I now going to be eligible to re-sign up?
Well, the facts, I would say it depends. Lawyer answer, it depends, but the eligibility under 5490 requires that you had to have been denied returning for failure to defer. So it's likely that if you had not known about retiree coverage leaving from the OMAP school district 10 years ago, didn't know to defer, if you had contacted the PEB program and said, hey, I didn't know that I need to do anything, but I'd like to come back, and they said, oh, sorry, you didn't submit deferral forms, but the answer is no, then you've met that prong of eligibility, but then you would had to have appealed that denial. So the appeal is another narrowing of the funnel, because we know a lot of people were denied for failure to defer their eligibility, but if they didn't appeal that denial, then they don't meet the eligibility under 5490. So it would depend on if that individual had appealed and had submitted an appeal by last year, then there's potential that they would be eligible under 5490. But without that appeal, they would not be eligible per the requirements of the legislation.
Is there any timeline on when that appeal would have to have been submitted?
Yes, the timeline on it is it must have been submitted. You must have appealed, meaning I think we would interpret that by you had to have submitted your appeal to the program by the end of last year. So December 31st of last year was the deadline for having submitted those appeals to be considered eligible under 5490. That's why we know it's a fairly narrow population, because those requirements had to have been met in order for them to regain eligibility. And then in those instances when they had regained eligibility, they're only eligible to enroll in Medicare supplemental or Medicare Advantage plans, and not Medicare Classic for those employees or those retirees. Next slide, please. So the other two pieces of legislation that we're currently implementing, 1008, again expanding that definition of separated employee. This goes into effect for retirees or separate employees effective 1/1/2024. So we're currently drafting emergency rules so that we can have rules in place for the start of the year, so that any employees of either the PEB or SEP program who separate, meet the requirements, and are Plan 2, TERS, PERS, or CERS enrollees, that they would be eligible to enroll in retiree coverage. There's also 5275. This is the creation of employer groups in the SEP program. The nice thing is that we've got a pretty good example of how to have a process for enrolling employer groups into the PEB program. So we're mirroring that process for the SEP program with some nuances. Of course, there's a little bit difference in the population that would be eligible to be an employer group, and also the school board members have a different process that they will have in this SEP program. Currently, school board members are permitted to participate on a voluntary basis in the PEB program, but they must do so through their school district. Under the legislation under 5275, those school board members are able to participate SEP of their own volition. They don't need to go through the school district for any sort of contract with the agency. The school board members are just permitted to obtain benefits through the SEP program on a self-paid basis. And of course, that also has emergency rules that we're in the process of drafting up. So then I think that's the end of my slide. Next slide, please. All right, I'm happy to take any questions. Otherwise, I think that's the last you'll see of me on the legislative side of things for this year. And again, I want to appreciate all of the staff who put in thousands of hours in making this a priority. They did an excellent job this year, so thank you to the team for all the work they did.
I think we have a question in the room.
How did the pet insurance bill fare?
Pet insurance, oh right, that's great. Pet insurance did pass, so the Office of Insurance Commissioner now has regulatory authority over commercial pet insurance. I think what we will see is a commercial group product for pet insurance probably come along in the next couple of years, which will be interesting to see what that looks like and see what the rates are. The SEP board currently has the authority to offer pet insurance to their population. That was legislation that had been passed a few years ago with the launch of the SEP program that extended certain optional benefit offering authority to the SEP board, which did include pet insurance. I know there is planning for us in the upcoming session or two to introduce legislation that would expand that same offering authority to the PEB program, which includes things like pet insurance, legal insurance. There's a whole slew of different rental insurance, different benefits that can be offered. Now in the SEP program, those are offered on a 100% voluntary and 100% employee paid basis. At least that's per the statute. They've not done that yet. They've not gone and offered any of that yet. But it's certainly something we can see happen in the future. There's no immediate plan to do so. I know it's now getting to that place where we'll have a regulated pet insurance market, and we could see something come up in the years to follow. I'm sure that both boards will be made aware of that in the event that does move forward. Thank you for the question.
Any other questions?
Yeah, this is Monica. I'm sorry, I was using the raise hand function. Given the special session specific to substance use disorder, does that have specific implications for the board, or will that be something that we would be reported on in the next legislative calendar?
I think it's a really great question. I'm not sure of the direct program implications. PEB had said that it has. I know certainly the agency and our Division of Behavioral Health and Recovery is going to be heavily involved in that. Dave, do you have any more information about that you could share?
I don't, but if there is something, it's important to remember that a special session can be called for one topic, but once the legislature's in town, they can talk about anything. And they could be here for up to 30 days, even if the hope is that they are here for a few days. So, the special session was called to continue the discussion on the Blake decision. But if anything comes up, Kate will be back, and if there's any implication for any bills that happen in the special session, then in fact, Kate will be back as part of a special session review. But we're not aware of anything at this point that would directly impact either of the PEB or SEP programs. But if there is, we'll bring it back.
Great, thank you.
Any other questions?
Just lastly, I do have an appendix slide here that lists the pieces of legislation that I talked about during the year that did not make it to the end of the finish line. These are all being introduced by rule next session for the short session, so we could see these come back up. I won't go through any of them, but they are here, so we don't forget them, and we'll be tracking them again next year when we use them up. Thank you, everyone.
Thank you, Kate, for that insightful and entertaining presentation. I didn't think insurance could be funny, but apparently it can. Next agenda item, 23-25 biennial budget update. Tanya Dool, the ERB Finance Manager from the Fiscal Services Division, is going to provide an update on the biennial budget. Keep in mind the governor has not yet signed the budget bill. Materials are behind tab number 6. Hey, Tanya.
Hi, good morning. Thanks, Chair McDermott, members of the board. For the record, my name is Tanya Dool. I am the ERB Finance Section Manager, and I'm going to give a quick update on the final biennial budget. First up is the funding rates. So for the newer board members, just a quick reminder on what a funding rate is. We have lots of rates we talk about, but the funding rate is our main source of revenue. This amount is paid by each agency and higher education institution on behalf of each benefits eligible employee, and it's paid per eligible employee per month to HCA. This amount is set to cover medical, dental, vision, basic life, and LTD, as well as some administrative costs, and also can use any available surplus the program has or fill any deficit. So just some background on what a funding rate is. So for fiscal year 24, this amount was set at $1,145, and for fiscal year 25, $1,191. Again, these are per eligible employee per month. Both of these rates we feel really good about. We review all of the underlying assumptions that the legislature uses to set these amounts. HCA, of course, does modeling to recommend numbers, and then the legislature has the authority to set the final numbers. We have reviewed the underlying modeling, feel confident in the numbers, no concerns. These numbers are set to maintain all of our current benefits, as well as fund a couple decision packages. Before we talk about those decision packages, I do want to note one other thing that is included in the funding rate that is not a result of a decision package is the funding of the collective bargaining agreement for healthcare. That was negotiated last summer, in summer of 22, and includes funding for switching the methodology for medical and the employer's contribution from a state index weighted average approach to the employer medical contribution approach, which is benchmarked off of a single plan. We will talk more about that again and do a refresher when we walk through rates later in June. Next up is the Medicare explicit subsidy. It is set in the budget at $183 per Medicare retiree per month. This is maintained from calendar year 2023. As a reminder, this amount is set at the $183 or 50% of the premium, whichever is less. Next up are three decision packages that were included in the final conference budget. First up is our TPA spending authority. TPA is our third-party administrators for our self-insured medical and dental products. This is Regents for the Uniform Medical Plan and Delta Dental for our Uniform Dental Plan. Each year we reassess the enrollment within our self-insured products, and we typically have a decision package each session that goes in for those enrollment adjustments and increased spending within our self-insured TPA budget. Next up, there was funding received for one FTE in the ERB division for the support of VEBA, which is the Voluntary Employees Beneficiary Association. This is a new FTE within ERB. I do want to note that this $316,000 is a biennial amount, so this is not a single salary for a single year. This includes benefits, their salary, as well as some expenses to actually house an employee, and this is a biennial amount. Next up is standalone vision, and this is actually a reduction to the budget. It is not a reduction because it's a cut to benefits. It's a reduction to carve out our vision to a standalone product. We will be using fully insured standalone vision carriers versus including it within our uniform medical plan, which is administered by Regents. So this is just a reduction to those administrative fees paid to Regents. So effective January 1 of 2025, we will move vision from being embedded within the medical products to standalone vision, and will become 100% employer paid, and this is for our employees only. Tom, I see you have a question.
Before you ask your question, I just want to give a little bit more context on the standalone vision. You won't be seeing more from us this board season about this. This changes for January 2025, but you can expect more information and some possible decisions that need to be made by the board during the 2024 season. I also want to highlight that we won't do a public procurement for fully insured carriers for a standalone vision hardware benefit because we did that procurement to launch the SEP program. And when we did the original SEP procurement for vision benefits, it included the authority and ability to use that same procurement and resulting contracts for the PEB program if the decision were ever made to have standalone vision hardware benefits in the PEB program. So no public procurement is necessary, and we'll be discussing this a lot more because the next board season as it has an implementation of January 2025. Tom, what's your question?
I think you pretty much answered.
All right.
I'm glad to be anticipatory helpful. Back to you, Tanya.
All right, thank you. Next slide, please. Next up is some new language, proviso language within the budget. The first item Kate spoke about in detail, which is we received $78,000 for the implementation of House Bill 1804. This is the bill that allows retirees to basically come back into coverage. Kate went into this in detail. I'm hoping he's here if anyone has any further questions on that. Additionally, we received $500,000 to produce a Medicare report. We have to provide the legislature with a report on the findings from all of the listening sessions that Ellen's been briefing the board on, as well as an analysis of governmental self-insured plans that have benefits that are equal to or richer and have more affordable premiums than UMP. So more to come on that. Next up, we have direction for HCA in consolidation with, or in coordination with OFM to look at the consolidation of the budget structure for PEB and SEB. I do want to just emphasize this is not a direction to consolidate our programs. This does not commingle our funding. We will still be accounting for PEB and SEB funds separately. It's just a technical kind of behind the scene things of how we will submit our budget with one single program to OFM, but like I said, all funds will still be separate and we will still be doing all of our projections and our rates separately for the two programs. And last up, one piece of language that is new is as the public health emergency is coming to an end and federal requirements for carriers to cover over-the-counter tests for COVID are also ending, our final conference budget included language that allows for UMP to continue covering 2 over-the-counter tests per month per member with no cost share. And I will pause there because that is the last item and take any questions. All right, thank you.
Thank you, Tanya. Next up, UMP Hearing Instrument Benefit. Janice McAlpin, Senior Account Manager from the Employees and Retirees Benefits Division, and Sarah Whitley, Finance Manager from Financial Services Division, are going to provide us with some more information regarding UMP's Hearing Instrument Benefit and introduce a proposed resolution to implement a bill from this past session. Janice's and Sarah's materials behind tab number 7. Welcome.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Janice McAlpin, and Sarah Whitley and I will be co-presenting on UMP hearing instruments today. Going into the next slide, here's a high-level overview of the evolution of the hearing instrument benefit. So this illustration shows where we were prior to 2021. That's on the far left-hand side in the blue circle, where we're at currently there in the middle, and where we are headed next year on the far right-hand side. Prior to plan year 2021, the UMP hearing allowance for hearing instruments was a total of $800 every 3 years, and that was for either 1 or 2 aids in total. That means that a member was provided reimbursement for up to $800 for hearing instruments every 3 years, and any costs above that $800 were the member's out-of-pocket responsibility. Based on what we know about the average cost of a hearing instrument, prior to 2021, most members were obtaining hearing instruments and they were paying a significant amount out of pocket, and that suggested that $800 was not set at a sufficient coverage level. During the 2017-2018 legislative session, SB 5179 passed and required coverage of hearing instruments every 5 years for PEB and SEB employees and dependents. This legislation resulted in the current benefit coverage today for hearing instruments in UMP, which effectively provides full coverage at 0 member cost share for up to 1 instrument per ear every 5 years. And that's in the middle current state there in the green bubble. Now going on to the next slide, we'll cover where we're going at for January 1st, 2024. This is HB 1222, and it was signed by the governor last week on May 4th, and this expires the current law as of the end of this year, December 31st. The effective date of this legislation is January 1st, 2024, and it impacts the general large group commercial market health plans, and that includes the employees and dependents of PEB and SEB program plans. It requires coverage for hearing instruments, not including OTC hearing instruments, at no less than $3,000 per ear, with hearing loss every 36 months. And for most of the UMP plans that are not high deductible status, it would be not subject to the enrollee's deductible unless that plan is offered as a qualifying health plan with this health savings account. And going into the next slide, I will pass the mic over to Sarah to go through data and utilization.
Yeah, thank you, Janice. So at our meeting in March, we brought the board a few slides featuring claims data that supported our discussion around how changes in hearing aid utilization and unit costs were identified as a possible area of focus for UMP. And in our March presentation, we included data for claims that were incurred and paid through only September of plan year 2022, which really provided partial insight into the 2022 plan year utilization. Since that meeting, we've received another 3 months of data with claims for services that were incurred and paid through December of 2022. And so we brought an update on this information because we think this additional data helps us give a more accurate picture of what we're seeing for hearing aid utilization into plan year 2022. It is important to note that we don't consider data reliably complete until we allow for processing of claims through March of the following plan year, so that would be March of 2023. So the results for 2022 cannot yet be considered final and may increase once we have that full run out for these completed claims. So this slide is again organized by those two key drivers that we covered in March, utilization on the left-hand side and unit cost on the right. The bar graph on the left of the slide shows the distinct count of members with a hearing aid claim in each plan year. So the lime green bar is experience for the PEB Medicare risk pool, the bright blue bar is PEB non-Medicare, and the gray blue bar there is the SEB UMP member experience. So it's clear that we are seeing some dampened experience when we compare the 2022 experience to plan year 2021. But we are still observing much higher than average when we compare to the historical utilization for hearing aid benefits in plan year 2022. The patterns observed in large unit cost increases beginning in plan year 2021 persist into plan year 2022. The table on the right-hand side of the slide here shows that on average across all programs and risk pools, UMP is paying approximately $5,700 per distinct member with a claim in plan year 2021 and $5,800 per distinct member who had a claim for hearing aids in plan year 2022. The average UMP paid amount is of course calculated as the sum of all claims divided by the number of members with a claim in each plan year, and given the nature of an average, we wanted to include a sense of claims that are contributing at the higher bounds of that average calculation. So the second row featured on this table includes the maximum UMP paid claim amounts for plan years, for both plan years or across all plan years really. And in 2022, we're seeing hearing aid claims paid as high as about $20,000. And in 2021 as high as $17,000. Moving into the next slide here, this slide features total UMP paid amounts for hearing aids by program and risk pool. Again, with an additional 3 months of data, we're seeing a similar pattern observed in plan year 2021 persist through December of 2022, with much higher than historical annual paid claim amounts for the benefit, being driven both by utilization and unit cost of hearing instruments in UMP. Again, I want to note that with additional times for claims to fully complete, we do expect the 2022 numbers to increase slightly from what you see here today. The data presented today can't be considered fully complete just yet. Oh, we have a question from John.
Yeah, I'm curious, what constitutes that extra $15,000 in the highest claims? Is it medical services that are provided with regard to hearing? Or is it actually the equipment, the hard equipment? Are they buying a better piece of equipment? And how do you control that?
Yeah, John, that's a great question. So when we pull these hearing aid claims, we're looking at procedure codes specific to hearing aid hardware. So those higher paid claims, and we can dig into this and bring some more information back. But those are claims for the hardware associated with hearing aids. So that would be a set of 2 hearing aids, and I know this from memory because I just looked at it the other day. That was a member who received 2 hearing aids, and UMP paid the claim at as high as $20,000 for that member.
Thank you.
You're welcome. Dave, do you have anything to add there?
I have a couple of things to add, but I was going to wait till another slide, but I'll circle back to a little bit of additional thoughts on that one, John.
Perfect. Okay. So I think we can move into the next slide here if there are no other questions. So this is also an updated graphic from our meeting in March, and it provides a more granular level breakdown of UMP paid amounts, this time by cost range per hearing aid claim. And this has been updated again to reflect the 2022 plan year experience. In March, you saw a similar slide that reflected 2021 plan year experience. Each bar representing program and risk pool provides a count of distinct members with a claim for hearing instruments that fell within that cost range during the 2022 plan year. And again, we're seeing a really similar pattern persist with significant variation in UMP paid amounts by member with a claim. The buckets include, again, the count of members with a paid claim in each of those cost buckets, and then they vary from a lower range of between about $0 and $4,000 per member to claims greater than $9,000. So that brings us to our next slide here, which brings us to what insights we're able to glean from the data. And that's really my favorite part about crunching numbers and finding patterns, is uncovering the underlying theme that helps guide us toward a data-driven decision. And the 2021 and 2022 plan year data tells us that about 80% of members who had a hearing aid claim in plan year 2022 received 2 hearing aids, with only about 20% receiving 1 aid. With that context, and connecting that data point with what we know about the average paid per distinct member, we see that UMP is paying an average of about $6,000 per distinct member. We can therefore conclude that on average, UMP is paying about $3,000 per hearing aid for all members across PEB and SEB programs. Given these insights, the plan experience in 2021 and 2022 support that a $3,000 per ear coverage resulting from House Bill 1222 would maintain a sufficient and valuable hearing instrument benefit for our members. And from a cost containment perspective, given that unit cost is really a key driver for our significant increases in UMP paid dollars, the results of House Bill 1222 are assumed to place downward pressure on member premiums for both Medicare and non-Medicare UMP plans within the PEB and SEB programs.
So Sarah, this is where I was going to chime in with a little bit of additional information. It's no coincidence that $3,000 here from the data that Sarah has presented aligns with House Bill 1222's floor of $3,000, because the 2021 UMP data was provided as insights to legislative staff and legislators as they were considering House Bill 1222. You may, if you look at the history of the bill, notice that the bill was originally introduced with a $2,500 minimum benefit, but our experiential data in UMP helped guide the decision to ultimately amend that bill to a $3,000 limit. So I did want to kind of tie that together, that the data that we have with the billed amount payments that were being used as the basis for paying charges in the Uniform Medical Plan in 2021 did guide decision-making on the bill that ultimately passed. It's also really important to know that when we think about average, that typically means, the 50% mark. Half of the people are paying more, half are paying less. That's why the context that Sarah provides of the maximum paid and those outliers, which can skew an average, is so important to keep in mind. So it is not, and that's also why the prior slide shows the actual counts of utilization by dollar bands and $1,000 increments, to help reassure you that although 5,800 was the average, a lot more than 50% of individuals were paying less, 5,800 or less. It really is being skewed by a couple of outlier claims. And then another question that I often get asked is there another example of this in history of kind of a high cost benefit that had wide ranges of variable expenses? Well, unfortunately, that happens a lot in healthcare. Part of the Healthcare Authority's job is to have data analytics to identify that variability and then bring proposals to the various authorizing environments to try to address some of that variability that may or may not relate to quality. But a perfect example that is actually very analogous to this situation is pediatric vision hardware benefits. After the ACA was passed, there was mandatory coverage for pediatric vision hardware, and it did not have a specific cap. So what we found in in the data was a wide range of hardware. And as we dug into that data, we learned that some individuals were getting designer glass frames with designer labels on them. And because the law says that hardware must be covered, insurers, including Uniform Medical Plan, were paying full amount, including for a range of high-end designer glasses. And so there were measures put in place to identify what would be an amount that would ensure a high-quality benefit that would have meet people's needs, and in the context when you ship that to hearing aids, has the things that people anticipate are standard aspects of a hearing aid, to make sure that there is not a disincentive, or in fact no incentive, to consider cost at all when looking at hardware. And so there's a very similar experience. In fact, when we first started looking at the data on hearing aids, the first analogy that was made was, "Ooh, this is pediatric vision hardware part 2." And so I just wanted to highlight that there is some kind of precedent for this type of scenario, that the $3,000 that ultimately was in the bill was guided by UFP data. The average definitely does not represent 50% of people paying that amount, or the 50% paying that amount. And that we do believe that the $3,000 would set a benefit that includes all the standard features that people have come to expect within hearing aids at this point. So those were just some initial pieces that answered some questions that I've been asked over time. I have a little bit more as we go further into the slide deck, but I'm going to pause for Monica. You had your hand up first, and then Elliot. So Monica?
Yeah, I'm curious. I know that this does not cover the new OTC hearing aid benefit. Do you see any synergy or overlap or any impact or potential, or are these completely distinct in how we as a board are thinking about the two benefits?
Very great question, Monica. The legislation is very specific to not including OTCs, but the proposal that Janice is going to describe and how it would be implemented has a feature that the Uniform Medical Plan has always found a way to credit OTCs if there's also a prescription. So the kind of separating the delivery method for getting the hearing aid versus the medical determination for that hearing aid. And so we've historically had a way that if you get an over-the-counter hearing aid, yet you also have a prescription, there's a reimbursement mechanism with UFP. Janice will describe that there's a similar phenomenon to describe that because the law doesn't prohibit that. And so we're looking at continuing that tradition within UFP within the proposal. So most insurers may not couple those things, but we have that historical practice in UFP, and we're looking at a way to kind of perpetuate and continue it.
Great, because I mean, this is also going to have implications for the FDA decision yesterday to have progesterone-only pills over the counter as well. So it's good to hear that. Thank you.
Yep. Elliot?
Yes, I was wondering, since you have this analogous situation with the pediatric vision hardware, is there any way to bring the board back information on the results of downward pressure on premiums as a result of that law change, so that we can actually look, I mean, I know, Dave, you and your staff will cover any differences that we need to take into account, but it may give the board some concrete recent example of downward pressure on premiums over a span of time.
Yeah, absolutely. We'll take that back as a piece. It's also why we introduced it and asked for action at a separate meeting so that we can do these types of follow-ups. I do want to highlight one challenge here because I don't want people to walk away with the wrong impression of what downward pressure means. And then we'll transition to Sarah talking a little bit more about this on slide 8. We're saying downward pressure at this point because when you're looking at rates, there's so many pluses and minuses that are happening in the system that you can't one should not just focus on a single instance of downward pressure as resulting in, say, ultimately a premium reduction. Because if, let's say, this benefit limit of $3,000 per year is put in place, that won't in of itself necessarily overcome inflationary pressures or medical trend pressures. So while there can be downward pressure, it's almost the way when someone says, you know, it could have been worse. It's downward pressure that if it doesn't overcome medical trend and inflationary pressures, premiums still go up, but premiums could have gone up even more. But we can talk a little bit more about what that incremental impact was in the pediatric vision as an analogy, as we also work to bring you more refined estimates of what we think that looks like in this particular instance as well. We're just not ready for that yet in May. Our rate setting process really, where we are really digging into the numbers and dissecting and doing modifications is in the beginning of May. So that's why we have our general rate setting process in June and July. We share some things with the board about the negotiation process under the Open Public Meetings Act executive session rules, so that the board has some pre-awareness about kind of what is happening with some of the potential changes in rates. But then we will bring information about that in June and July, depending on that you're on here. Elliot?
Yeah, I think specifically it is helping me when I read this to think of the down. It's not that the rates would go down necessarily, but they could have been higher. Like you're saying, it could have been worse. So I think if we think of it in that way, it's probably a bit more realistic to think of the effectiveness.
Yes, if trend is +5 and this benefit limit puts downward pressure of 1, that's still a +4. That means premiums
Right.
go up.
So if you could, when the information's there, present that kind of information, that context, it may be a more realistic goal for your audience to expect.
Perfect. Thank you, Elliot. Appreciate that. I'm going to turn it back to Sarah to go over to slide 8.
I think Michaela had a question here in the room.
Yeah, just a quick question. Does this include cochlear implants or no?
We can take that back officially. We'll have to take into consideration an HTCC decision with UMP, so we can bring that back at the next meeting.
And for everyone who's not aware, HTCC is the Health Technology Clinical Committee, which makes determinations on emerging or recent health technologies industry and makes specific coverage decisions about what can and can't be covered in state versus healthcare, which includes the PEBB programs.
Great. So all of that discussion leads really well into our next slide here. So this assumed outcome slide just takes our discussion one step further. And what we've done is using the 2021 claims experience, we've analyzed the assumed outcomes of House Bill 1222. Had it been in place in plan year 2021, based on the plan year 2021 experience, UMP claims liability would have been approximately $6 million lower. And as a self-insured plan offering, UMP premiums are established based on the assumed projected costs to cover the healthcare claims incurred by members in the plan. So speaking back to some of this, inflationary pressure, if healthcare cost liability increases, upward pressure is placed on member premiums to cover the cost of that projected increased liability. And vice versa, as healthcare cost liability in UMP decreases, downward pressure is placed on premiums. And we know that in general, healthcare inflation is on an upward trajectory, but we are projecting the outcome of this change to place some amount of downward pressure on inflation in UMP while maintaining access to a quality and essential benefit for members. And as Dave mentioned, we are prepared to bring some information on that later on in board season. So furthermore, when we spoke to you in March, we also mentioned that the current benefit provides a lack of incentive for members and providers to avoid high-cost instruments that may not be medically necessary. The benefit levels resulting from House Bill 1222 and the proposed resolution that Janice will present here today should lead to providers steering members toward lower cost but still high-quality medically necessary options. And it is important to note that members can still select the higher end hearing instrument with some of the bells and whistles that aren't necessarily medically necessary, but they will and must pay the difference between the health plan coverage and the cost of the item out of pocket. Janice, did you want to take us into the final slides?
Thank you, Sarah. So far the board has heard about what we used to do prior to 2021, what we're currently doing right now, and where we're headed for 2024. So for your review and consideration today to vote on at the June 8th board meeting is the proposed resolution 2023-03 for UMP hearing instruments. And that is beginning January 1st, 2024. Prescribed hearing instruments in all uniform medical plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. So coverage for members enrolled in UMP Classic, UMP Select, and UMP Plus are not subject to the member meeting the plan deductible, and coverage for members enrolled in the UMP Consumer Directed Health Plan, CDHP, are subject to the member meeting the plan deductible first. And again, this will be on the agenda for the June 8th board meeting for a vote. And going into the next slide, I'll give you a few examples of what implementation would look under this proposed resolution. So if a member purchases a set of hearing aids this year in December 2023, for example, under the proposed resolution, they would be able to purchase a new set of hearing aids under the new benefit January 1st. Another example is if a member purchases a set of hearing aids in January 2024 under the new benefit, they would be able to again purchase another set of hearing aids as soon as January 1st, 2027, at least 36 months later. And what kind of Dave talked about earlier about OTCs is that under this proposed resolution, we wouldn't be changing anything for UMP. The bill does not mandate coverage for OTC hearing instruments, but if you have a hearing exam, prescription requirements are met through UMP, you could get reimbursement for your OTC hearing instruments that way. And now going into some further next steps is HCA will be sending out stakeholder feedback by tomorrow, and we're going to ask for that back by no later than May 22nd. We will incorporate that feedback into the proposed resolution and then the next presentation on June 8th, and we'll bring that back for a vote at that meeting. And
this is Dave. I just want to say we'll bring back, as Sarah was alluding and I was alluding, additional financial information. I do want to highlight that the $3,000 could be revisited by the board in the future. The legislation does give the discretion. We believe that the $3,000 is appropriate to propose here. That's why I was highlighting earlier the connection between how that number was reached for the bill that passed the legislature, and it's dovetailing now with the proposal that we're bringing you. But if $3,000, if we hear concerns or data suggests that a different number, we can always bring something back to the board in a future year to adjust the benefit again. And then the second piece is I just want to be very clear for both the board and the public that this is a proposal for all parts of UMP and PEB. So that's both the employee setting, the non-Medicare retiree setting, and the Medicare setting. It's everyone, all UMP plans, and we have a similar proposal before the SEP board as well.
thank you, Dave. That brings us to the end of our presentation. If there are any questions.
Any questions from the board? All right, we're going to go ahead and take a recess for about 6 minutes. We'll return at 10:30. Actually, Tom?
Yes, I'm wondering, we received a letter from Fred Yancey, specific to his concerns about this. I'm wondering if, instead of moving on and waiting until the very end, after we've had conversation about other topics, if we can perhaps get Fred's, because I know he's invited to attend this meeting, we can get his perspective now.
Dave, any issues with that?
Chair McDermott, is the chair's discretion to allow public comment on other topics, and so
So you're putting it on me.
your choice.
I hear you. All right, are there others besides Fred that want to speak? Okay. Fred, you're on.
Thank you very much, Mr. Chair. Fred Yancey, on behalf of the sorely back. Yeah. I think my letter speaks for itself. I was not prepared to speak, on the issue. So my concern is, the board needs to understand that there will be a loss of benefits for, a significant number of members with this change in place. And I still have concerns as to what I know it's a cost containment issue. And the concern is really, the net effect of reducing benefits, what it will do to, will it be justified by this downward pressure? And, I'd just be interested in the data. It's great. I appreciate, David, you making the statement that, the board can revisit this benefit in the future. And hopefully this 3,000 will do it. But I don't know enough about the hearing aid world to know what features you get beyond $3,000 that could substantially add to somebody's quality of life. There's different levels of different qualities of hearing that are restored, and those qualities, I'm sure, are tied to the price of the instrument itself. So what benefits of somebody giving up in terms of quality of hearing? I don't know the answer, but I appreciate the opportunity. My letter's, outlining some concerns, and I look forward to continued discussion. And again, David, I think you mentioned, or the other staffers kindly mentioned that, this proposal will be circulated in the field and the stakeholders feedback too. So it'll be interesting to see who's paying attention. Thank you very much.
I appreciate your comments, Fred. Why don't we go ahead and recess then until 10:35. Amy, you have a question?
Yes, I do. Thank you. Thank you, Chair McDermott and board members. And also thank you, Mr. Yancey. I do think that this is a change for a number of individuals, and hope that there will be some method of advising stakeholders as to how this is changing and when, and that the resolution will be proposed at the June meeting. It just has to do with how many people we saw using this. There must have been a huge demand to incur the expenditures that were incurred at the time, especially in 2021. So I just would like to bring that forward. Also, of interest, I think it would be useful to know how other states are working with hearing instrument benefits in plans that are self-insured for public employees, and being able to make some comparison. It is people who were not aware that this was in the legislature may not have had an opportunity to make their views known, and it would be good to know how other states are handling this or have handled it, and will be continuing handling somewhat of this individual benefit assessment. Thank you.
Appreciate your comments. We're going to recess until 10:35. Thank you.
Engage in the system. A completely different system, not that this is being proposed in any way, shape, or form, is to require an active decision-making every single year. But this evergreen enrollment process has been ingrained in PEB culture, and most people, many people, are very happy with the services that they have in a given year, and if they aren't, then they're actively looking. And so one of the challenges I think that we've come to appreciate more as we've heard a little bit more about First Bill's implementation in particular is people who are happy are less likely to be engaged by the communication methods that we standardly use to promote changes. And sometimes it may be hard to identify which change would be the one that would be of most significant, that could put somebody in a position to think differently about their potential plan enrollment. But this has really just kind of raised on our radar the importance of thinking about triaging the types of changes that are made, and also identifying if there are other ways that we can be even more prominent for people who are already in a state of mind where they might not be engaging in open enrollment, to alert them that they may need to pay more attention to this open enrollment. So that's one piece. On this second bullet on lessons learned, I want to assure people, the board and the public, that these are types of questions that we ask. The key part that you're seeing here is written insights as part of our RFR process. We definitely have conversations about impacts to various parts of the population, including rural communities, on benefit design changes. So I don't want anyone to walk away from this thinking HCA never asked about rural impacts. We absolutely do. The key part here is working in our renewal process to have anticipatory, written, proactive insights from carriers when they're submitting these types of proposals, so that it doesn't have to come as dialogue after the proposal comes in, but it's purposefully thought of, written, and described as part of our renewal process. And these are just 2 lessons learned. There are likely others. And again, I opened up the board meeting by highlighting when we got to this presentation that we wanted to highlight how we communicate. I know that we've received feedback about the level of information that was in each of these communications and how clear network status was or wasn't. And that's also valuable feedback for how things are framed both by a carrier and by the healthcare authority. We did think it was important though, to at least bring to the board, here's the ways in which we communicate, in addition to the messages that are in those communication methods. So just wanted to tie a little bow on my opening comments. And Elliot, I see you have a question.
Yeah, I think for the benefit of the audience, could you explain what a first fill is in this context?
Christine, please take away.
Yes, so first fill is embedded in the plan design, and so a member that it's for maintenance medications only, and there's a list of that on the the PEB Washington microsites. But the member, so if they go to fill this maintenance medication at a local pharmacy, they're allowed the first fill. Then they get a reminder letter from Kaiser Washington. You know, they notice that this was filled at a local pharmacy, and prompting the member to set up mail order. And it gives them instructions on how to do that. So if they go to do it a second time, they get another reminder. And if the third one, it'll deny at the local pharmacy. Based on how the program's set up. Nicola.
Sorry, I don't know how to raise my hand in real time, real space. So I think, Dave, I think you do this already, but wanting to make sure, and then if we can, to call it out when we say insights on impacts unique to rural members. It seems like it should be broader to expand like anyone with accessibility issues, because when I think about first fill and the implications on people who might live in a place where they don't have secure mail or that have just kind of multiple issues of not having convenience to be able to set that up, that it just wanting to make sure that we're being more inclusive about who we're considering in that.
Absolutely. Thanks, Michaela. I would say yes. Yes.
Good point.
Christine, as we get back to your presentation, I also want to highlight that I said at the last board meeting, I believe it was the last board meeting, sometimes it's hard to keep them in order. There will be conversation and information brought to the board about whether to continue the First Fill program in 2024's plan design with KP Washington plans. And we'll be bringing some information preliminarily in executive session, and then there'll be public conversation about it in the June and July as we finish up the rate setting process. But this is just to describe the historic piece, and again, the way we communicate. It's not to say that there's a decision that's been made, and we'll be bringing you information for you to make a decision for 2024 related to whether to continue this practice in the KP plans and have, and we'll be doing the same thing with the step board. Christine, why don't we go back to you?
Okay, next slide, please. So on screen, there is a statement from KP WA outlining its ongoing focus related to high quality and accessible care that is also affordable. And I'm not going to read it, but it is available for those that do. And questions, please.
Any questions for Christine? Seeing none. Christine, thank you so much.
Thank you.
Yep. Next agenda item, Medicare update. Ellen Wolfhagen, Senior Account Manager in the Employees and Retirees Benefits Division, is going to provide us various topics related to the Medicare population. Ellen's materials are behind tab number 9.
Good morning, Chair McDermott, And members of the board, sorry about that.
That's all right.
It's usually my name that gets messed up. As promised, I'm here for an encore presentation on more Medicare issues. For the record, my name is Ellen Wolfhagen, and I'm Senior Account Manager in the Portfolio Management section. Our topics today are processes for pharmacy appeals in various plans. I have some further information that was requested by Chair Birch on CAPS survey information. I'm going to give a recap on the listening sessions and public forums, and then some information on what we're doing on retiree communications. Next slide, please. So, generally speaking, the pharmacy appeal process is the same in all of the Medicare plans. The initial denial is made by the plan. And the reasons could be there was no prior authorization, or it required step therapy, or there's a quantity limitation. Quantity limitation would be something like you can have either a dosage limit or you have a number of doses available in a specific time period. The denial can be appealed back to the plan with an exception I'm going to talk about. And if the plan still denies, the appeal is routed to an independent review organization. Part B drug appeals in any plan are handled as Medicare appeals, and all Part D appeals are Medicare appeals. Next slide, please. So in the Medicare process, the initial denial of either a Part B drug or a Part D drug goes to the plan. Medicare requires that if sufficient documentation is not received within 72 hours, the initial decision is a denial. And that's a reason why there are many more denials in Part D plans than there would be with other pharmacy plans. The provider or the patient can ask for expedited reconsideration. It can be requested by phone. A decision happens within 72 hours of receipt. The plan either authorizes and provides coverage, or there's a denial. And at this stage, if it's denied, it goes to an independent review organization. Next slide, please. The independent review organizations are hired by Medicare. They are not associated with the carrier, and they are not a governmental agency. So the plans have no say in who their independent review organization will be. Standard appeals for Part B drugs and Part D drugs are answered within 7 calendar days unless more information is required. Expedited appeals are answered within 72 hours of receipt. Before I move on, are there any questions about the pharmacy appeal process? Michaela?
On the 72 hours of receipt bullet, do we have any data that shows like how often a backlog might impact that, or is it?
I can research that, but per Medicare requirements, it's they have to answer within 72 hours.
Okay.
Oh, a member of the public has a question?
We're going to save that until public comment.
Oh, okay, thank you.
Yep.
Okay, moving on to the next slide, please. So this is information about the United Healthcare CAPS survey. Chair Birch asked last month about the enrollment numbers. Remember that the CAPS survey is done on all of the national level Medicare enrollment in the group Medicare Advantage plan that is run by United. So I have updated numbers for January 2023. As you can see, the number of members nationally has increased every year for United, and our PEB numbers are reflected as well, and you can see that we're now inching up towards 1% of the population being enrolled in PEB. Elliot, you have a question?
Elliot?
Yes, who performs these surveys?
So the CAP surveys, as I went over last month in the board presentation, are done by the Agency for AHRQ. It's Health Quality and Review, and that is a branch of the Federal Department of Health and Human Services. So these are not done by the plans. They are an independent survey.
Thank you.
Yes. Tom, you have a question?
I just want to make sure I'm understanding this. Look at 2021, 1.5 million members, nationwide, 3,196 PEB program members, and then that 0.21%, I'm assuming that represents the number of people who actually participated in the survey?
No, no, Tom, that's the percentage of the national population that are actually PEB members. So 0.21% of the national population are PEB members.
Okay, thank you.
You're welcome. Okay, next slide, please. So listening sessions, it's been a very busy time of year. We've had 16 sessions so far to May 1st. I want to just make a note that we've had 4 since May 1st, so we're moving very rapidly in this area. The 16 sessions included 3 in-person sessions, and the locations are listed below. So far in these 16 sessions, we had 118 participants, 50% of which were enrolled in UMP, Classic Medicare. The initial high-level themes, and again, these are just summary themes, keep UMP Classic Medicare as an option. The costs are too high of both UMP premiums and United Healthcare Pharmacy were specifically called out as having very high costs. And HCA should continue to explore options for lowering UMP costs. Next slide, please.
Ellen, I just want to reinforce what you were saying, that those are just very high-level initial common themes. We will be going in much more detail as we work on that legislative report that's due in December, and kind of a wrap-up presentation about everything, and we'll have much more detail. So I just want to reassure everyone that we are not trying to gloss over feedback we're receiving. We're just trying to keep you generally at a high level as we're going along in the process, but we will be getting into much more detail as we continue going on in this process and evaluating all of the feedback we're hearing.
Thanks, Dave.
And Ellen, can you go back a couple slides? I believe that 0.21% is actually the PEB members against those surveyed. Is it the 1.5 million members responded to the survey?
No.
Or that's
It's
the total
population covered by the United Group
Got it.
Medicare plan.
I'm with you now. Thank you.
Yes. So that, just to reconfirm, that 0.21% is the number of PEB members compared to the national population in that Medicare Advantage plan. Thank you.
One more way to say it is take 3,196 divided by 1.5 million and make it a percent. 0.21.
Thank you, Dave. Okay, public forum. So the most recent public forum was held on April 26th. We have 2 more public forums scheduled, and they will be in May. We had 9 participants. The way that the public forum is set up, every participant has 3 minutes to speak. Again, at a very high level, just some of the initial feedback. Keep UMP Classic Medicare. There's a lot of dissatisfaction with privatization of health plans. There was an ask that HCA continue to explore options for lowering UMP costs, and a request to increase HCA transparency. Next slide, please. So we've been doing a lot to update our webpage and make our engagements with retirees more visible. And this is in part a response to the request for transparency, which we've heard in various settings. So the website has information about the listening sessions and the public forums. We have frequently asked questions. We've identified some common myths that people have about Medicare. And the FAQs from the listening sessions are being updated with each session that we go through, and the most common questions appear at the top. Next slide, please. This is a screenshot of how to find more information about the retiree engagement. And if you click on that, you come to a page that shows various subtitles, if you will. How is HCA connecting with retirees? How will feedback be used? What are we doing to what are we doing as retiree engagement? I'm sorry, why are we doing retiree engagement? And as mentioned before, the FAQs and Medicare myths. And that's my presentation.
Do we have questions from the board for Ellen? All right. Ellen, thank you so much. Now we're at the public comment. If there's anyone on Zoom that would like to provide comment, please raise your hand, and then we will get our list together and start doing that. How many folks we got want to make public comment? 4 folks. Okay. And that's Ms. Mulder.
Hi, this is Linnea Mulder, and I would like to thank Ellen for revisiting the pre-authorization process. And I thank Kate for the good explanation of Bill 1357. Hopefully that will prevent delay and denial of care, which is very common now. I'm still wondering, even in the setting of 1357, if it would be helpful for members to make an informed decision during open enrollment, if it would be helpful to provide links to the pre-auth and appeal section of each insurer. Luke Dearden actually did this for me in 2022. It was very helpful. If members are interested, it would make it easier to find that information than to try to go through 200 to 300 pages in each certificate of coverage. My second question has to do with listening sessions and the legislative report in December. I'm wondering, how will HCA determine the findings and what data will be provided to support the findings? Thank you very much for the opportunity to speak.
Thank you. Amy Fortier?
Thank you, Chair McDermott, members of the board. I'm Amy Fortier from Sequim, Washington. I just want to say thank you for this continuing information that we're receiving prior to considerations of resolutions. It's very helpful. Do have a concern about more outreach for members who will be impacted when these resolutions are both proposed and voted upon. And being able to get good data is very useful, especially as people are sometimes impacted without their knowledge. And it's much better relationship for everyone to know about it ahead of time and be able to look at some options for resolution. Coordination of benefits. I want to keep emphasizing, I think it would be helpful to be looking at what that is going to continue to look like. I'm also interested, again, I think, not to beat the dead horse, but what are other states doing that have self-insured plans? What are they doing in the arena, not only, as we heard today, of hearing instruments, is carving out a vision. I'm very concerned about some of these elements that would make it more difficult as a consumer of healthcare and health insurance in making decisions and having to constantly be vigilant of changes that are underway that impact us.
So we'd like to ask the board to consider having additional data at presentations from other states with either similar or comparable plans, and also be able to have some outreach stated for each of these proposals when they come forward. Thank you for your time.
Nathan Johnson.
Yeah, I'm Katie Johnson from Tip Clock Drug, and thank you for everybody who reached out to us after the last time we talked. But just here talking about the Kaiser First Fill program again, after reviewing the slides, I mean, it's great that they did try to get this out to members, but at the end of the day, like 99% of the people coming in here to the pharmacy did not know about it, and so it just wasn't effectively communicated to the members, at least here it seems. And then once the patients were locked into the mail order requirements come January, Kaiser did a great job of communicating it. I mean, they were relentless with phone calls and multiple letters for every medication that was filled outside, so it seems like they know how to get it out there. They just didn't want to during open enrollment because of pushback. And you know, now patients say they get multiple phone calls a day sometimes telling them you have to transfer. And I did have one patient who saw something on the First Fill program, and she reached out to the Kaiser member services and said, I fill everything at Tip Clock Drug, is that going to be a problem? And they told her, nope, that is an in-network pharmacy, they're contracted with us, no problem. And there was no mention to her of, oh, but if you're on maintenance meds or anything like that. So it seems like maybe Kaiser didn't educate their employees that were fielding these calls very well either. And I mean, going back, the real issue is patient care. And it's just going to continue to go downhill because there's no incentive for Kaiser mail order, you know, to really provide excellent patient care because they know that the people have to go there. People come here because we offer a great service and they, you know, appreciate that. But when they're forced to use a mandated mail order, they're just gonna get what they get, and that's the way it is, which is really unfortunate for our members.
Yeah, we recently, just on Monday, transferred a prescription to Kaiser mail order, where the patient was going out of town and she thought Kaiser, she had to get it through Kaiser. So we transferred it, and she called Kaiser to have it mailed on Monday. She's leaving town on Friday, and they told her, quote, I hope so. I hope it gets to you. So, I mean, that's a week where, so the next day she called us back to see if we could get another prescription for her. Thankfully it was for, she was still on her grace fill for the second fill, and we were able to get it, ordered in the next day. She got it on Wednesday. I mean, that's patient care right there, being able to get the medication for the patient when it's needed, and not just I hope so. It was an inhaler. Was it Lipidat? Maybe, maybe not, but it was insulin, and it wasn't in the grace fill period of time. Now she's paying $500 out of pocket for it. Or she goes to the ER to get something. There's an ER bill, so the cost goes up, healthcare, so, which can increase hospitalizations. And so being able to say that they can save cost is give or take. It might save cost on the actual drug itself, but in the long run, for the whole scope of things, and with elderly patients, retirees having to use mail order, yeah, it's not the best system when people want to talk face to face with their healthcare workers.
All right, thank you.
Yes, thank you.
Matt Grosjean, am I butchering that?
Yeah, Matt Grosjean, thank you.
Yeah.
Thank you, Chair McDermott and members of the board. I have a question about listening sessions. First of all, thank you to HCA. This is a big investment for the listening sessions and the public forums, and I really appreciate that. My question is, since the notes and analysis are being done in-house rather than by a professional third party, what is the plan for input from the coalition in development of the legislative report? The coalition has had note takers at every listening session and public forum, and it is important that the final report accurately reflect retiree concerns. Thank you.
Thank you, sir. And Aruna Bhuta?
Good morning, Chair Ron McDermott and the board members. My question is around 5490, the deferred benefit. How can we have the HR department informing the people who are leaving the organization before their retirement age that you will be eligible for the benefits? Because quite often the HR department is not informing. Like one of the board members had a question about, person who separated from SEDD, 10 years ago, whatever. And second comment I have is around customer service staff being informed about the changes, especially with United Healthcare Plan. When you call them, you're just going from being transferred from one number to the other numbers. So Kaiser not giving accurate information to the enrollees, as well as customer service of United Healthcare being less than helpful at all after waiting, just for sometimes hour on end to be able to get some accurate information during open enrollment. Thank you.
Thank you. Any other comments? And I know that in those comments where we've questions as well, and I know that at the next board meeting we'll address those questions that were asked. Elliot?
Yes, I do have a comment because one of the members of the audience brought up something that is kind of important to me as well. I worked in many agencies of the state and I was staff. And especially crafting legislative proposals, before we did that, we always looked at what other states have done and informed the department of that. And yet, when certain things come before HCA, like UHC has been in many other states before it came to Washington. And I, as a board member, would have liked to have known what the experience was in those other states, and it was as though they were in Liberia. We had no information on that, and I think it would have been helpful, both pro and con. Thank you.
Amy Fortier?
Thank you again. Chair McDermott, members of the board, Amy Fortier, Spring, Washington. Just a little different tack on this. Dave, you mentioned something about the HTTC. That was a new organizational name to me. I'm wondering too, in these developments of resolutions, if there's some thought towards innovation. And I appreciate Elliot's comparison for states. I think that's very good to have included. What are other states doing with similar plans? But might we also hear about innovation and if there are some new or different things that are being tried and something to opt in or opt out or make a choice of. And just would like to put that forward and to see if there's something to be considered that could be valuable from a cost containment standpoint. Thank you.
Thank you, Amy. Tom? Tom, I think you're on mute.
So I'm assuming when Kaiser came up with the first bill, they had some assumptions about how much money they would save by doing this. I'm wondering if we know how much money they intended to save by doing this, and if we could get that information.
All right, we'll have a look at that. Others? Nathan Johnson?
I just did have one comment on that. What's interesting is, so patients would fill their prescription here and say it would come up with a copay of $5.20 and then they would get the call from mail order and they would transfer it to mail order, and they never thought to ask, will my copay be any different or anything? And then I had a patient who, the very same medication, same quantity, everything, mail order charged her $11 and some cents. And so from a cost containment standpoint, it seems that Kaiser has different pricing depending on if they're reimbursing a third party pharmacy like us versus reimbursing their own pharmacy, because what it actually did was make the member pay $6 more for the same thing, and she had the inconvenience of having to set up mail order, and she was not happy about it. I know she put in a call, to Kaiser and to the Office of Insurance Commission, and so it just seems like it would be really nice to get some data from Kaiser to show this is how much money they are saving, the healthcare authority and the patients, because from what patients are telling me, I don't think it's saving the patients money. Maybe it is saving money on the plan, but it would be interesting to see those numbers.
All right, thank you. That's the end of public comment. Next up, we have the 2023 board season schedule is posted. Is it the 2023 or 2024?
Still 2023.
Still.
Just a reminder that the full meeting schedule is in
I see.
our packets.
Okay. Yep, it's posted on the HCA website and is always part of the briefing books, which normally posted to the website on Monday before each meeting. Our next meeting is scheduled for June 8th at 9 a.m. to 1:30 p.m. with the same format here at HCA and available on Zoom. Dave, any final comments before we head into exec session?
I'd just like to do a preview of topics for the next board meeting. So we'll be bringing back Janice's proposal that was on hearing instruments, as well as additional information related to some questions there. Something I'm very excited to remind everyone or share with everyone that we'll be bringing to the next board meeting is a topic we're calling coordination of benefits state analysis. It's something that we've been working on since the end of last board season to be able to do exactly what some of the requests have been today about what other states do with Medicare setting and coordination of benefits plans. And just a preview, what's pretty unique here, most states aren't doing what we do anymore. I do know that Chair Birch had mentioned the number 10 before. We'll talk about what that number means, but it's not 10 states even. It's less than one hand, much less than one hand that have something that would be remotely considered comparable to what we're doing here. But it's an important analysis that we've been working on. It's quite a challenge actually to come up with the state comparison piece, but we're excited that that's finally ready to bring to the board next meeting. And then last, I do want to highlight that we anticipate a substantial executive session next meeting, and to the extent board members are able to come in person, I really encourage you to come in person if at all possible. I think it will benefit during that particular executive session. I haven't had a meeting yet where I've suggested to board members that they attend in person, but I do suggest doing it if you can attend. And if there's any coordination on that front for travel, Jessica could support that. And just want to thank everyone as the Chair can take us to executive session.
All right, thanks, Dave. Executive session is going to happen here in the Sue Crystal room for board members and include HCA employees. At this time, members of the public joining us in person at the Healthcare Authority today, as well as employees not part of the executive session, will be escorted by staff to the lobby for the duration of our exec session. You'll be called back to join us in Sue Crystal for the remainder of the public meeting, which is basically just going to be a brief statement to formally adjourn the meeting. after the exec session has concluded. Pursuant to RCW 42.30.1101I, the board now will meet in exec session to consider proprietary and confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 41.05.026. The executive session will conclude no later than 12:25. All right.
Chair McDermott, I just want for the record to correct, and we'll be clearer on the agenda in the future. The citation for the session is 1L as
sorry.
Larry, not I as an igloo.
Okay.
But I know that Katie and Michael, our AGs, would have encouraged me to correct the record on that.
RCW 42.30.1101L. Noted. Board members, let's take a 5-minute break while we transition into exec session. We'll return to our public meeting to adjourn after the session is done. Thank you. All right, we're back from executive session, and this meeting is adjourned. Thank you.